Hi, I'm Dr. Peterson with Regions EMS. I'd like to take a few minutes to go over several of the new guidelines from the new guidelines. Let's go to the last group of guidelines, the Special Response Guidelines. This section contains an MCI triage reference, 2 rehab guidelines which are intended for special events and prolonged public safety incidents, as well as 3 patient care guidelines for unique situations. Let's start with Guideline 73, the MCI triage guideline. There are several triage algorithms that can be used in mass casualty situations. This guideline is based on the START algorithm, which stands for Simple Triage and Rapid Treatment. The pediatric enhancements are called Jump Start and help you make objective decisions rather than emotional decisions when faced with injured children. The entire triage process for a single patient should take less than a minute and involves first separating the ambulatory patients from the non-ambulatory, followed by evaluating breathing first, perfusion second, and mental status third. Children should be prioritized during the secondary triage process, and any infant with any sign of life should automatically be categorized as red. This guideline would be a good reference to have available in an MCI kit, along with several tourniquets, chest decompression needles, and a collection of oral or nasal airway adjuncts. Guideline 74 is probably one of the most useful additions to the collection. This probably won't be appropriate for a 911 response, but is intended for use at any event where EMS is asked to provide standby care for spectators or participants. Many patient encounters at sporting events, concerts, or community events are related to environmental stress, such as prolonged heat or cold exposure, and regardless of how sick they initially appear, most people will improve dramatically with some basic common sense interventions. This guideline provides a clear framework for rehabilitation in these circumstances. All of the care provided under this guideline is at the BLS level and does not require a full patient care report or even MRCC contact. Agencies that choose to use this guideline for a special event should maintain a log of individuals evaluated and treated under this guideline to document that an actual evaluation took place. In a nutshell, a basic set of vitals should be obtained, and if they're not drastically abnormal, the individual should be sheltered in a climate-controlled setting for 15 to 20 minutes, orally rehydrated, and either warmed or cooled, depending on the context. At the 20-minute mark, a decision should be made as to whether the individual can be cleared back to the event, is improving but would benefit from additional rehabilitation time, or is either failing to improve or continues to have abnormal vital signs and should be escalated to the level of a full patient encounter. This would then warrant a full evaluation and treatment according to the most appropriate guideline, documentation in a full patient care report, and contact with MRCC regardless of whether or not the encounter results in a transport. Guideline 75 is very similar to the Special Event Rehabilitation Guideline, but is intended for use with public safety responders on the scene of an emergency. As with Guideline 74, if the care remains within the scope of this guideline, it is not considered a full patient encounter and would only require a log entry in place of a full patient care report and MRCC clearance. This guideline is consistent with the NFPA Standard 1584, which guides the provision of incident rehabilitation services for fire departments at emergency incidents. At Regions EMS, we feel very strongly that it is not our place to make operational recommendations. When and how to initiate fireground rehab is an operational decision that falls under the incident commander. Once that decision has been made, however, the medical care that's provided does fall under the medical director's authority, and this guideline is intended to provide a clear treatment algorithm for those situations. The guideline is very simple and should be used in conjunction with the heat stress and cold stress management principles from Guideline 74. Responders will be asked to remove all burdensome personal protective equipment, rest for 20 minutes, and consume a minimum of 8 ounces of fluid. If vital signs remain abnormal after this rest period, further rest and hydration should be considered, and an intravenous fluid bolus can even be considered for those with significantly abnormal vital signs. At this point, then, the responder should either be cleared for duty, pulled from duty, or transported to a hospital for further evaluation. The medical providers should make clear recommendations, but ultimately we feel the authority lies with the rehab officer within the incident command structure to clear or pull responders from the line of duty. Guideline 76 might be one of the more interesting guidelines in the book. Although exceedingly rare, fortunately, LVADs, or left ventricular assist devices, pose a significant challenge for emergency responders and seem to defy several basic biological principles. The single most important principle in dealing with an LVAD is that with most devices, the pump is continuous rather than pulsatile. Therefore, you will not be able to palpate a pulse or measure a blood pressure. Treatments should instead be based on your clinical judgment as to whether or not the patient is adequately perfusing. Most patients will have a go bag with extra cables and batteries and will probably know more about their device than you will, so use their knowledge or their family member's knowledge to ensure that the cables are properly connected and the batteries are fully charged. The patient should also have contact information for their VAD coordinator, and this person should be contacted immediately to help coordinate a treatment and disposition plan. Many patients with VAD devices will chronically be in dysrhythmias related to their underlying heart condition. However, if signs of poor perfusion are present, those dysrhythmias should be treated appropriately and even defibrillated or cardioverted as indicated, as this should improve the cardiac output. Interestingly though, CPR should never be performed on a patient with a ventricular assist device unless it is specifically mentioned in an advance directive and after consultation with the patient's VAD coordinator. Trauma from chest compressions during CPR is almost certain to dislodge the device and cause massive bleeding in the chest, which would limit any further resuscitation attempts. Once a decision has been made to transport, patients with ventricular assist devices should only be transported to Fairview University or Abbott Northwestern within the Twin Cities. The Mayo Clinic is the only other facility in the state capable of managing patients with these devices, but is out of transport range for most of our agencies. Family members and the VAD coordinator will be your best resources on scene for management decisions. Moving on, Guideline 77 provides a reference for managing patients with tracheostomies. Tracheostomies, or trachs, are actually very simple to manage. Caregivers and family members will most likely be able to provide assistance with the device, and most patients even have extra supplies available. Your management priorities should be checking the equipment, suctioning, and then assisting ventilations with a bag valve mask. Let's first start with the equipment check. If the tube has been dislodged, first you need to determine how recently the trach was placed. If it's less than 6 months old, the stoma has not fully matured, and it is possible and even likely that you will create a false tract in the neck if you attempt to reinsert the device. After 6 months, this should not be an issue, so you can either replace the trach tube or insert a small endotracheal tube into the stoma to facilitate ventilations. If the trach is intact, check to make sure the appropriate parts are in place. Most trach tubes are double lumen, meaning there is an inner cannula which can be removed to facilitate cleaning of the tracheostomy. There is also an obturator, which is used when the trach is inserted. This should be removed immediately as it occludes the tube. This should never be present when you arrive on scene, but it is something to check for. Some patients may have a Passy-Muir valve, otherwise known as a speaking valve, which should also be removed if respiratory difficulty is present. At this point, the remaining outer cannula should be suctioned, and deeper suctioning can be performed by a caregiver if needed. Further distress should be managed by assisting respirations with a bag valve mask and treat according to the standard respiratory distress guideline. Another critical point to mention is that most patients with tracheostomies can still be orally intubated if there is a catastrophic failure of the trach site or if the appropriate tracheostomy equipment is not available. This would also be the preferred intervention if the trach stoma is less than 6 months old and the tube has been dislodged. All right, this brings us to the last guideline, number 78, emergencies involving ventilators. The easiest way to manage a ventilator emergency is to disconnect the patient from the vent and manually ventilate them with a bag valve mask. If that does not resolve the issue, consider the DOPE mnemonic and check for tube or trach dislodgement, airway obstruction, or pneumothorax. E stands for equipment failure, which we have already addressed by disconnecting the ventilator. If the tube is dislodged, consult either the tracheostomy guideline or the standard adult airway guideline to reestablish an airway. Obstruction is most commonly due to excessive secretions, so a thorough suctioning will usually resolve that issue. A pneumothorax would be a clinical diagnosis, and if significant distress is present, you should consider a chest needle decompression and use caution with excessive positive pressure ventilation. This would be very rare, but should still be on your radar. Whenever possible, bring the patient's ventilator to the hospital so it can be checked and adjusted if needed. If appropriate, you can continue to use the patient's own ventilator during transport at their baseline settings. Unless the call happens to be a critical care transport, you should not adjust any ventilator settings. If the patient appears to be in distress, you should assist ventilations with a bag valve mask. The guidelines reviewed in this video are intended for special situations and most likely will not be part of your day-to-day operations. Because of that, they should be reviewed periodically so that you are familiar with the general concepts and can reference them as needed. MRCC operators are always available by phone or radio to clarify the guidelines. And as always, the staff from Regions EMS are always more than happy to answer any questions or concerns you might have.